Hello, everyone, and welcome back to another VMR. My name is Shema. Today, I again have the honor to discuss with my dear friend Rabih, and as a case presenter, our dear friend Aisha, who's also a team member, she is going to present a case to us, and I'm so excited and just wanted to ask her whether she could unmute.
Hi everyone, my name is Aisha and I'm so excited to present a case. This case was given to me by Dr. Rabih, one of the mentors in our group as well. And I'm so excited to hear your teaching points, Shema and Rabih. Let me know when you would like me to get started.
I love that you inserted me as a casual addition at the end because it's 100% true that most of the teaching will be coming from Shema. I think there's somebody here, one of our team members, who yesterday said to me, quote, gosh, when I grow up, I want to be like Shema. And I think that I was telling said team member who I'll keep anonymous unless they want to reveal their identity. They're free to do so. By the way, Deborah just got here, so I think we're good to go. But I think it's so symbolic of what's happened in CP Solvers. For those of you who have been here for a long time, you'll have probably seen Shema's emergence as a initially very shy and reluctant facilitator to one that everyone here expects to do most of the teaching, which is just unbelievable. It's really, really cool that you haven't affixed the MD label on your name yet, and yet you're teaching all these people. And I think the amount of accomplishments you've had at the level of your training is literally mind-boggling. And I think you can retire at the tender age of a junior faculty member at this rate if you really want to. So you're setting yourself up for that life, Shema. It's really, really cool to see. I also wanted to say hi to a few people who have turned their videos on that I am either seeing again or haven't met before. Tim, it's so nice to see you again. What are you up to?
Nothing much. Applying to fellowship right now, and saw a VMR that worked with my schedule, and was so excited I could join. So I'm happy to be here.
How's Shifir going?
Oh, it's going wonderful. We're really excited to have you and Reza in about a month at
Yeah,
Oakland
exactly
in
right.
person.
Yeah, a little less than a month. We're really, really excited for it and excited to join you guys and meet you in person again and see you in person again. Amazing. I also see Masa, you turned your video on before. I don't think we've ever met. You mind introducing yourself to the VMR crew?
Hi, I'm Mata. I'm from Dubai. I'm currently in Indiana doing a rotation, and I'm applying to match this season.
Oh, amazing. Amazing. Welcome.
Yeah,
You have a lot of Middle Eastern friends around you. Ibrahim is currently in Saudi and
yeah, I realized.
yeah.
Hi, yep,
And
yeah. This is my
Aisha.
third session, and it's
Oh, your
been
third session. Okay, cool,
very
cool.
informative. I'm
That's
enjoying
awesome.
it.
That's awesome.
Yep.
Well, thank you for returning your video on. It makes a huge, huge, huge difference. I really, really appreciate
Yeah,
it.
of course. Thank you.
Elena, what have you been up to?
Not so much. It's kind of loud here. I don't know if this is okay.
Yeah, we don't hear it
Uh,
actually. We just hear you. Yeah.
yeah, I've been following the sessions.
Yeah. I think you're like the most I think you're here more often than I am, which is really cool.
I don't know about that, but yeah, yeah, I'm enjoying it. I'm learning a lot, and I'm realizing how much there is still to learn.
Oh, welcome to the club, my friend. Welcome to the club. Yesterday, one of our academy members, Austin, presented a case on RLR that only Mariana knows the diagnosis to, and the story for that is a very long one that I won't spare you with. But yesterday in that case, I learned that I had so much left to learn. It's unbelievable. I also want to say hi to Eduardo. Hi. Thank you for turning your video on.
Hello, everyone. I'm Eduardo from Mexico. I'm glad to be here. It's been like 2 months or more that I start watching these videos, and I'm glad to be here.
Amazing, Eduardo. I don't know if you can see your screen, but Yaz is literally beaming from eye to eye as she is also from Mexico, though she's currently in Texas now. But I'm sure you guys have a lot to chat about, given your
Sure.
similar origins. Welcome to VMR. It's very, very nice to see you.
Yeah, thank you.
Shema, I hope I bought you some time to relax, get comfortable, And I bought enough time for Aisha to turn her video off. I don't know. Okay, there you go. All right, Aisha, we're ready to go whenever you are.
All right, sounds good. Just give me a second. Okay, I'm ready. So today we have a 35-year-old female who presented to the ED with left-sided chest pain for the past 1 week.
Okay, I think I would then start for chest pain in general. If it's acute, we have our very famous 4+2+2 mnemonic that we always go through. So we have to exclude all the life-threatening things. So for the cardiac causes like acute coronary syndrome, tamponade, Takotsubo, and aortic dissection, and for the two pulmonary causes, something like PE or pneumothorax, and then the esophageal causes like rupture, impaction. And yeah, like 35-year-old generally is a very young age that I don't associate. Like, I mean, I would like to know whether she has any kind of past medical history for any hypercoagulable state, because when I think of a young female with chest pain in an acute setting, would rather go to something like PE. So would like to know whether she's on oral contraceptives, whether she has any risk factors for any hypercoagulability. But before going much into detail, I would like to know more about, yeah, I would like to ask Rabih.
Sorry, folks. I don't know. My video is stubbornly just staying off. I don't know why. Yeah, Shayma, I completely agree with you. I think you need a lot more information. And I think that we've talked about chest pain over and over and over again, that it really helps practice that same routine. Yeah, I'm really curious. I see you just noticed that it's 1 week, which is interesting, right? I'm glad that you didn't know that before, because it now allows you to really try to get as much juice and as much information about that new fact. So what does that do for you that it's 1 week? Did it surprise you, or how did you feel when you realized it?
I have to say, it definitely shifts my differential. Like for hyperacute things, I tend to think of pulmonary cardiac causes, but for like 1 week, go more into superficial causes and like anatomical causes. Like, is there any issue with the skins, or I don't know, or in the chest wall? Like we know sometimes something like anything like Bornholm disease or costochondritis, we can also present with chest pain. So that, and also any intra-organ process that can radiate, that can also present with chest pain. So that definitely shifts my differential right here.
I completely agree with you. I think that if you do the extreme of this exercise and say a 35-year-old woman presents with 1 year of chest pain and call it chronic, it becomes very, very obvious that some of the things that we worry about would not be at play. And I think the reason for that is that if you just think hard about why we care about chest pain, if you ask yourself, if the whole problem is just that somebody's chest will hurt forever, that's not great, but it's not so bad, right? That's the same exercise we do in patients with headache. If the whole problem for the rest of the life of the patient is that their head hurts, but not that they have paralysis or confusion, then that's not great, but that's much worse. So if for a whole year, the only thing that ever happens to a patient is they get chest pain, it tells you that the consequences that we really worry about, namely cardiopulmonary or esophageal compromise or dysfunction, if they haven't happened for 1 year, what are the chances they're gonna happen tomorrow when the patient comes to see you? So remember really that a big principle here is we are trying to see if a pain is turning into or going to turn into a dysfunction. The only reason acute medicine pays attention to pain from a diagnostic perspective, it's supposed to be a warning sign that something worse than pain is going to happen. And this is why chronic pain is so problematic, because by definition, nothing worse than pain has happened. And so the diagnostic opportunities tend to be limited. So the general principle that you're saying, Shema, is the longer that a syndrome stays just limited to pain, the more likely it is to be a problem with the alarm rather than it to be a problem in the actual system itself. But unfortunately, 1 week is too short to commit to that conclusion. It certainly suggests it. And we haven't heard yet whether this patient has some dysfunction. Does she have shortness of breath? Does she have fever? Does she have some kind of consequences? But the general principle, I think, applies. The longer that a syndrome remains focused on pain without dysfunction, the more likely it is that the alarm bells, i.e. the pain, is the problem, rather than some sort of issue as a warning sign. But there's another feature here, I think, Shema, that's really interesting, which is that she is young. So what did that do for you? And how would it be different if you had misheard and thought that Aisha said 75, and then you realized, oh, wait, it's 35? What would have happened in your mind?
I mean, generally, if she was older, for sure, in older people, I am also aware that we are also naturally immunocompromised. So thinking of things like zoster or even also cardiac causes. And usually we also tend to have more musculoskeletal issues, chronic pain. But in a young patient, usually I don't expect that, unless she has any autoimmune condition. So that's what I think about.
Yeah, I agree. The two leading causes of morbid chest pain, acute coronary syndrome and pulmonary embolism, are strongly associated with age. Acute coronary syndrome is age associated because coronary artery disease is age associated. Pulmonary embolism can be caused by many things, but one of the biggest risk factors is age. And the older you are, the more likely to have PE. So the fact that she's young reduces the probability of coronary artery disease. And the fact that she's young reduces the possibility of pulmonary embolism. But the problem is there are other reasons to have ACS, for example, coronary dissection. And there are other reasons to have PE, for example, an autoimmune disease. So all of the considerations are at play. So I think at the end of the day, chest pain is so morbid that nothing changes the approach initially, but the fact that she's young reduces the probability of coronary artery disease causing ACS, and the fact that her pain has been persistent for 1 week is reassuring, but we have to wait to see if she's incurred some dysfunction as well. All right, Aisha, tell us more, please.
That was such a good discussion so far. Shane, what you're doing is amazing. Okay, so history of presenting complaint. Her chest pain was non-radiating, and it came on and off, which was exacerbated by exertion, and it wasn't alleviated with any medication or like Tylenol. And on review of systems, it was only evident for chest pain. She denied fever, chills, palpitations, dyspnea, nausea and vomiting, and diaphoresis. For her past medical history, she has SLE, and she had a PE in May of 2021 while she was on Eliquis, and lupus membranous nephropathy and hypertension. For her family history, her mom has a history of clots, and who's taking warfarin. Social history, she's a non-smoker, does not consume any alcohol, no history of substance abuse. Her meds include Eliquis, hydroxychloroquine, losartan, tacrolimus, mycophenolate, and belimumab. Yeah.
Okay, so we got a pretty rich history. So seeing that she only has chest pain but no other systemic sign of fever makes me not rather think of something like inflammation. You know, when I saw the past medical history of lupus, I tend to think of things like serositis, so can present with myocarditis, pericarditis. But seeing that she doesn't have any kind of fever makes it less likely for me at the moment, but it's still not excluded. And then also seeing the medication history. I mean, for sure, she has a family history with clot, so it would be interesting to see whether she has any risk factor I mean, she also had a PE in like 2 years ago, to see whether she's at risk again for a PE, because that makes it likely. And then with the medication that she's getting, like Eliquis, so rivaroxaban, I don't know whether she would be still at risk for something like PE while she's on rivaroxaban. And also taking into consideration that she's taking hydroxychloroquine and MMF, that she's also at risk for infections because she's immunocompromised. So that would be my initial thought at the moment. What do you think, Rabih?
No, I completely agree with you. It's amazing how that history of lupus changed everything. I'm curious if we take a moment just to study the HPI before we definitely reflect deeply on her medical history. Is there anything in the HPI that caught your attention?
So basically that it is like it has an intermittent character that is like it reminds me more of something like, how can I say, when I think of I only know the German, colic, like this intermittent pain. So
Yeah.
I'm still not
I
really
speak
sure.
German. I know what that means.
Oh, okay.
It's the same word in English.
Yes, so we know this intermittent pain, if there's like any obstacle there that can cause this intermittent pain. So that's what I was asking myself, and it's exacerbated with exertion, but otherwise it's not radiating, so it's more localized. And I feel like the more localized it is, the more I think it's really more maybe an anatomical issue that is more localized and not really something that is spreading from anywhere else. But I have to say, chest pain is not my favorite chief complaint.
Yeah, I'm glad, because it usually means something's bad is happening to the patient. So I'm glad you're not loving it. As a general principle, Shema, whenever something is intermittent, I have one piece of advice for you, which is to try to have a simple schema. Intermittent is either trigger dependent or spontaneous intermittent. So an example of trigger dependent would be biliary colic. I eat and then I have right upper quadrant pain. An example of another example of triggered intermittent would be that I don't have good sleep, I get a migraine. Something that is intermittent but spontaneous is a kidney stone and renal colic. There's nothing I can do about the spasms of pain. So here, when you see that it's intermittent, do you see that there's a trigger, or do you see there's no trigger? It's that second sentence.
And the exertion.
Yeah. So now this is chest pain with exertion. What does that do for you?
I would rather think of any vascular problems. So is there any demand issue coming, like something like with the coronary vessels? Could there be something with anemia ongoing?
Yeah, there you go. Excellent. So now look at this, because ask yourself this question. Would lupus causing pleural serositis be chest pain with exertion?
I wouldn't expect it, especially for pericarditis, would be more a constant pain.
Right, exactly, right? See, so you can start to say, because lupus is such a profound influencer, but you can start to ask yourself, what are the relevant structures in the chest for me to try to assign what lupus can do to those structures? So you don't have to think about the whole chest, because chest pain with exertion helps you focus on a smaller set of possibilities within the chest, which you can then start to say, what are those things and how can they be related to lupus? So I guess we can start with the lungs. So because lung disease can definitely be with exertion, can you think of any lung manifestations that can be related to lupus?
Generally, for lung manifestations, thinking of something like fibrosis, thinking of so generally any interstitial lung disease. Otherwise, for pulmonary complications, also pleuritis would be also at yeah.
Agreed.
And also pleural effusion can go in with pleuritis.
Yeah, the pulmonary, it's interesting. lupus is one of the exceptions to the rule about autoimmune diseases causing ILD. It usually doesn't, but it usually causes an acute form of lung disease in the form of diffuse alveolar hemorrhage, or DAH. But chronic lung disease would be unusual. And you're right, pleuritis is definitely on the list. The vast majority of pulmonary issues, though, related to lupus are related to the treatment of lupus and the immunosuppression from that results in pulmonary infections. So pulmonary infection for sure, diffuse alveolar hemorrhage, and then pleural effusions. In general, though, pulmonary diseases don't usually manifest with chest pain with exertion. They often manifest as shortness of breath with exertion. So it's more likely that we're dealing with a cardiac or a vascular cause of chest pain that may be related to lupus. So if you think, can you think of any coronary manifestations of lupus?
I have to say, I have never come across about coronary manifestations in lupus itself. Just what you mentioned before, when you think of coronary things with young patients, so dissection,
Yeah.
still at risk. Otherwise, when you mention vessels and lupus and this association with APLS, so still at a risk for hypercoagulable state. So I still wouldn't exclude the possibility of any kind of thrombosis.
Excellent. Absolutely superb. I think thrombosis, spontaneous coronary thrombosis, or even coronary embolism so you can get Liebman-Sachs endocarditis, and that can embolize to the coronaries. But the most common manifestation of many autoimmune diseases in the coronaries is accelerated coronary artery disease. Many inflammatory conditions such as lupus, psoriasis, cause accelerated CAD. So the most common manifestation is CAD, but you can get coronary thrombus and coronary embolism. And I think that theme of thrombosis probably also extends to the pulmonary artery and causing pulmonary embolism, which this patient already has. The medications also show up in the heart. This is a very esoteric question, but I also saw that she's on tacrolimus, and the manifestations for the medications can also cause a myocarditis. Specifically, hydroxychloroquine is known to cause a myocarditis, and tacrolimus is known to cause a hypertrophic infiltrative cardiac myopathy. So Shema, you can see that lupus causes devastating consequences in every part of the chest: the lungs, the pleura, the coronary arteries, the pericardium, the myocardium, the endocardium. So you can ask yourself, how do I make progress when everything else is on the table? Everything is on the table. So I'm curious, what are you most hoping to get on exam? What would be very helpful for you to figure out on exam to try to distinguish between the fact that she can have a problem anywhere, basically, in her chest?
Well, basically, during the PE, looking for the posture. So is she using any accessory muscles? And also, generally I use my stethoscope to see, do I hear any heart sounds? Is there any kind of crackles that we can hear? And yes, and generally also looking for some skin signs. But I feel like that the physical exam itself won't help me that much. It can only give me a hint. Is it more cardiovascular or pulmonary? But generally, I would like to later see on with the EKG and so on what is going on, and also with the metabolic labs. What do you think?
I completely agree with you. I think our next task is, when you realize that lupus can affect everything in the chest, is to try to make progress on localizing the lesion. Where is it? And once we localize the lesion, we can start to run the DDX. But the whole point of that in conversation was just to show you that lupus can do anything in the chest. And the next goal of this case is to say, where is the problem? And then we can start to think, what is it? So I agree. I think the exam and the data, we should put on our hats of let's localize a lesion and make Aaron proud, although he would be allergic to localizing a cardiopulmonary lesion. All right, Aisha, tell us more.
So many good teaching pearls so far. So the vitals, her temperature, she was afebrile. Her heart rate was 114. Her blood pressure was 131/82. And her resp rate was 18. And her O2 saturation was 99% on room air. For a physical exam, generally she is an obese female and she's not in any acute distress. She's alert and oriented to person, place, and time. Cardiovascular exam, there's no chest tenderness. She has a regular rate and rhythm, no murmurs. Pulmonology, she's clear to auscultation bilaterally, no wheezes or rhonchi or rales, and she has unlabored breathing. And for extremities and skin, she has bilateral pedal edema present, no skin rashes. And for labs, these are the labs at the time of her admission. So her white blood cell count was 5.2. Hemoglobin was 7.1. Platelet count was 536. Sodium was 138. Potassium was 3.6. BUN was 11. Creatinine was 0.9. Her high sensitivity troponin was 112. And her PT and PTT was also done. Her PT was 14.7. And APTT was 166. And there's also anticardiolipin antibody IgM and IgG, which was normal. But IgA was 31, which is borderline high. Yep.
Okay. So I'm trying to keep up what I now see in the whiteboard. So basically, she has bilateral edema. When we go through our edema, we think of heart, liver, kidney. With the lupus itself, I mean, seeing that she has this lupus nephropathy, I mean, it could be still due to something with the kidney. So some urine analysis would be interesting here. But also it could be something from the heart, but seeing that at the moment she doesn't seem to have any I mean, she's tachycardic and tachypnic, so I would basically still do something like an EKG. And the troponin was 120, but would be interesting to know whether the troponin was stable. So I would measure the troponin 2 hours later to see whether this is more of a chronic myocardial damage or acute. And seeing that the weight count is 5.2. Okay, that doesn't give me any kind of sign of inflammation. The high platelets is just, in my opinion, reactive. And the electrolytes seem also normal. What I don't understand, I would need some help. The IgA being high, what do you mean with the IgA? You mean the measured IgA or what directly?
The beta-2 glycoprotein 1 antibody.
Oh, okay. I mean, I have to say I never heard of IgA being high on beta-2 glycoprotein antibody. So I would have to ask you, Rabih, what to make of this high IgA.
Yeah, you know, I was worried that this would happen and that like we would get so much data and it would be very, very hard to try to make progress on it. And I think it goes to show you when you're taking care of a patient with lupus, it can get very complicated. So Shema, if we try to simplify our job and say, let's look at the exam and let's try to say where in the chest her chest pain is coming from, lung or heart. What do you think?
At the moment, I would say heart.
Yeah.
Because we don't get any signals from the lung at the moment.
Mm-hmm.
Yeah. So that would be my priority right now. And
Agreed.
Also with the troponin being high.
Agreed. I completely agree. And in the heart, What does the lower extremity edema do for you in terms of the kind of heart problem she might have?
There could be something like right heart failure happening. So definitely, I mean, for sure, you can have acute right heart failure in the setting of something like PE. So we still haven't excluded it.
Excellent. So Shema, can you walk us through how you got to what I think is the correct answer of right heart failure? What did you do? Can you just simplify that for the junior people on the call?
What was your question?
Yeah, you went from you very accurately said right heart failure. Can you tell us and just explain how you came to that conclusion? What is it about this case that made you think right heart failure?
Why I thought of right heart failure generally. So first of all, seeing that she has a high troponin, that she has a risk for any hypercoagulable state. She is at risk for something like PE. She's also tachycardic. So, and if we think of something like pulmonary embolism, it can present with right heart failure because due to the congestion that is happening and due to the vascular resistance in the pulmonary vessels, and due to the congestion, we tend to develop this edema. Yeah.
Excellent. And I love it. And why did you not think left heart failure? What about the exam made you think more right heart failure?
I have to say, because I have to say I don't associate generally left heart failure with edema unless it is very severe heart failure. And for left heart failure generally, I have to say I don't get any signal right here because the otherwise the cardiovascular exam was pretty normal and I would have expected any kind of anomaly.
Yeah, I think it's very.
And I see the clear lung auscultation. We would have expected pulmonary edema.
Yeah, I think that the normal oxygen saturation and the clear lungs reduce the probability of left-sided disease. And in the face of lower extremity edema and chest pain, I think what would seal the deal if we had a BNP or a JVP, but we learned that this patient is obese and as a result might not have an accurate estimation of her JVP. But I think right heart failure or disproportionate right heart failure is a reasonable working diagnosis because she's complaining of something in her chest. You see that she has lower extremity edema. And as you said, she's at risk for right heart failure. And you're right. Right heart failure, disproportionate right heart failure is usually the result of left-sided heart failure. But here we don't have any left-sided disease. So if you're starting to think about isolated right heart failure, disproportionate right heart failure, you should have two priorities, the two Ps. Pulmonary hypertension, either acute or chronic, or pericardial effusion. And I think that should be your first focus. And as you said, she's had a PE before, she could easily have it again. In terms of the labs, the most abnormal lab is her APTT. The PTT is normally 90, and her PTT here is 166. Just in general, Shema, what thoughts cross your mind when you see a very high PTT?
So generally, when I think of a very high PTT, so something like lupus anticoagulants could be at play. So we can have high PTT, but still are at risk for hypercoagulable state. Also, any kind of hemophilia, so hemophilia type A, B. So hemophilia can be acquired or it can be inherited. And also in von Willebrand factor deficiency can present with elevated APTT and generally so antiphospholipid syndrome. That's on my differential right now.
Absolutely superb. Yeah, there are 4 factors involved in the PTT: factor 8, factor 9, factor 11, and phospholipids. So deficiencies in either factor 8, factor 9, factor 11, or phospholipids can cause a prolonged PTT. patients with lupus are at risk for two conditions. The first is acquired antibodies to factor VIII, causing an acquired hemophilia. This causes patients with lupus to bleed. In stark contrast, patients with lupus are also at higher risk for getting antiphospholipid antibodies, or APS, and these patients are at higher risk for thrombosis. You may be wondering, why would I entertain the possibility of pulmonary embolism when the patient is taking Eliquis? But it turns out that antiphospholipid antibody syndrome is one of the few hard indications for warfarin or Coumadin, because the direct-acting oral anticoagulants are not as good as Coumadin or warfarin for patients with lupus and APLS. So if we take a step back, we have a patient with lupus who has dyspnea or chest pain on exertion, and we found evidence for right predominant heart failure on her exam, along with an elevated PTT. And I think that should make you really worry about acute or chronic pulmonary hypertension. But equally important is to think about the possibility that she might have a pericardial effusion. So Shema, what do you think would be a next step to help you understand the risk of PE and pericardial effusion? What test might you think of?
So generally, in a patient with high risk for PE, we would do something like a CT angiogram to exclude. I mean, usually we, in a case like this, I wouldn't send out the D-dimers because we are not that specific, and it doesn't really help me here out because she had a history for PE already. She's tachycardic, has this chest pain, so it definitely do the CT angiogram, and she's also hemodynamically stable. If she wasn't stable, I would have done an echo.
Ah, superb. You're a pro. And good news, the CT chest with contrast will also tell you if she has a pericardial effusion for free. All right, Aisha, tell us more, please.
That was amazing. So the next aliquot, I have some imaging. So her ECG was normal. Her chest X-ray showed cardiomegaly with a small left-sided pleural effusion. And her CTPE showed a thrombus in the segmental branches and in the right lower lobe. And I have some imaging which I can show right now as well. You see my screen?
Perfect.
So
Thank you. Yeah. Yeah, we see the X-ray now, and then this is the, oh, wow. You guys see the, Aisha, do you want to point out the clot? So, yeah. I don't know if you got, yeah, there you go. So that your mouse is over the aorta now, and if you go a little bit to the screen left, yeah, right there, perfect. Yeah, exactly. That's a filling defect. You see how the contrast is at the bottom at 6 o'clock. That's normal contrast. And then basically around the 9 o'clock to the 12 o'clock position is a filling defect, likely a pulmonary embolism. Yeah. Shema, you have a patient who is clotting on anticoagulation. Ah.
So I would basically go in what you said with it might be due to a possible APLS that she's having. So because it doesn't help here, this kind of medication. Another thing that I was really curious about when you were talking about, the causes for right heart failure, when you mentioned pulmonary hypertension, there's one teaching point that Ibrahim mentioned about the possibility for something like CTEP. So this fourth group of pulmonary hypertension, because she already had something like PE and they are at risk for pulmonary hypertension. So in this kind of patient, I mean, I would definitely do something like a right heart cath to give the diagnosis of pulmonary hypertension. I mean, for sure, we could do an echo to estimate whether she has something like pulmonary hypertension, but should definitely give the diagnosis of pulmonary hypertension, we still have to do something like a right heart cath. Yeah, and otherwise, seeing that she has cardiomegaly, what I learned from Dr. Ria is cardiomegaly on chest X-ray is either pericardial effusion or something like a hypertrophy. So we definitely do something like POCUS to see what it is.
You don't need me at all. I completely agree with everything you're saying. And to just emphasize that a pulmonary embolism should not cause heart failure. A pulmonary embolism acutely causes cardiovascular collapse, tachycardia, hypotension, but you should not have enough time from an acute PE to slowly get edema in your legs. The presence of a pulmonary embolism in the face of heart failure strongly suggests, as you and Ibrahim said, that the patient has pulmonary hypertension as a result, usually of chronic thromboembolic disease, but she may also have pulmonary hypertension as a result of her lupus directly. A right heart cath will help you establish if she has pulmonary hypertension. And the only way to distinguish between whether it is class 1 from lupus or class 4 from chronic thromboembolic disease with a high degree of certainty is to do a VQ scan. So yeah, I completely agree. Aisha, what did you guys do?
I also have the results for an echo, and then I can reveal the diagnosis. So the echo revealed a large pericardial effusion, more than 2 centimeters, with no tamponade. The ejection fraction was 60 to 65% with severe left ventricular hypertrophy and normal valves. And the final diagnosis was...
Actually, maybe before you tell us, I actually want to ask Shema because I think she will shine. So Shema, you ready? This is a very hard question, but a really important point. Aisha just told us that not only does she have a pulmonary embolism, but she told us that she has a large pericardial, well, a decently sized pericardial effusion. What do you think the cause of the pericardial effusion might be? What are your thoughts?
So generally that she could have, due to her lupus, some kind of serositis causing it. There would be so any kind of pericarditis that she also has. Yeah, so I think that she might have the chest pain due to something like pericarditis itself, and this right heart failure secondary to this chronic thromboembolic disease. So I think there are two things at play here, not just one thing.
Exactly right. I think that there are 3 overall mechanisms that patients on lupus with anticoagulation can get pericardial effusion. The most morbid is a hemorrhage from the aliquots into the pericardium, which is unlikely based on her stability. But you have to always recognize that you can have lupus serositis, but also that a patient with pulmonary hypertension can develop a pericardial effusion merely as a result of the venous congestion that happens in the coronary sinus. That latter hypothesis is really important to entertain because it signifies poor prognosis in patients with pulmonary hypertension. So the same reason that she can have edema in her legs is the same reason she can have a pericardial effusion. And so here the pericardial effusion may simply be a marker of severity of her pulmonary hypertension. And I think you might be easily tricked into thinking, oh, lupus serositis, but she doesn't have leukopenia. She doesn't have thrombocytopenia. She doesn't have an active kidney dysfunction. And usually all those are occurring in activation. So if I were to guess, I would worry most that she has a mechanical pericardial effusion, not an inflammatory one, as a result of her pulmonary hypertension. But finally, Shema, because I have to ask you a question at your discomfort zone, and I've tried for 47 minutes and failed miserably. So I'm going to try one more time. How do you diagnose APLS? How do we confirm it?
So basically what I remember about APLS, you need some clinical criteria and some and the labs have to be confirmed 12 weeks after, because like sometimes you can have positive lupus you can have something like positive, I think, lupus anticoagulants because due to inflammation or due to CRP, there's this kind of interaction. So generally you have to confirm 12 weeks afterwards. That's how I do. So we have this thrombotic complications or early abortions, so pregnancy complications. And if you also have these lab criteria 12 weeks afterwards, these antibodies, you can confirm the diagnosis.
Exactly right. Superb. In a patient with a high PTT, they're very likely to have a lupus anticoagulant. There are 3 well-described antibodies with APS and many other new ones. And the 3 well-described ones are actually alphabetically organized. Lupus anticoagulant with an A, beta-2 glycoprotein, and anticardiolipin. A, lupus anticoagulant, B, beta-2 glycoprotein, and C, anticardiolipin. Aisha sneakily only gave us the anticardiolipin and the beta-2 glycoprotein. Probably, maybe we'll learn that her lupus anticoagulant, which is the most likely test to be positive in a patient with a prolonged PTT, is positive, markedly so, or we may not have that information. But the reason I say that is because the type of antibody you have for antiphospholipid antibody syndrome correlates with the probability of the diagnosis. Because if you just sit for 3 months and wait for 3 months, a lot of bad things can happen to a patient 12 weeks apart. And so you have to try to say, well, what is the probability of APLS while I wait to repeat those tests 12 weeks or 3 months from now? They say 12 weeks to make it seem like it's a short time, weeks, but it's 3 months, Shema. So the lupus anticoagulant, the odds ratio of having true APS with lupus anticoagulation is over 10. So it's very, very high. And in most patients with APS, they are treated with either a heparin or a warfarin. So I say heparin because this patient's acutely sick, so she might get a low molecular weight heparin followed by warfarin. But yeah, I'll pass the mic to Aisha to tell us what the case conclusion was, and we'll acknowledge that I have yet to ask you a question, Shema, that you did not know the answer to. So I failed, but I'll try again next time.
Rabih, you're right. I do not have that information. Unfortunately, Dr. Rabih can confirm if he knows. But the diagnosis was a PE in the setting of antiphospholipid antibody syndrome. So this patient was put on Eliquis, and studies have shown that patients that have antiphospholipid antibody syndrome should be put on warfarin or heparin instead of Eliquis, which is apixaban. And so for this patient, the hospital course was her Eliquis was stopped and she was started on a heparin drip, and a large volume pericardiocentesis was done, which drained 850 cc of serosanguinous fluid, and a repeat echo was done 48 hours later, which showed only a mild amount of pericardial fluid that wasn't hemodynamically significant. And heparin was later discontinued, and she was bridged to warfarin with a therapeutic INR goal of 2 to 3, and then she was discharged home with a planned follow-up with a cardiologist at 4 weeks for a repeat echo to make sure there was no new pericardial effusion. Yeah.
Amazing. Actually, it's incredible to me how you can absorb a case that you just heard about a few hours ago and present it like no other. It was really, really cool to see that. So I really, really appreciate it. I'm curious, how did it feel to do that? How do you actually go about structuring this in your mind when you've only learned about the case recently?
I really enjoyed reading about it. So while I was reading up a little bit more, I found out that, so this patient, since she was an obese patient, studies have shown that patients with a BMI of more than 40 or a weight of 120 kilos should not be put on Eliquis, apixaban. They should be switched to warfarin or heparin. And this is because Eliquis is dosed based off of body weight. And sometimes patients can be underdosed because of this reason exactly. And also another reason why these patients with antiphospholipid syndrome are put on are preferred to be put on warfarin than DUAX is because of the concern for a lack of reversible agents if there's a concern of increased bleeding risks. And I really enjoyed reading about this within the last 2-3 hours since I got the case.
Yeah, that's
but
awesome. I'm not the
Yeah.
least bit surprised. Thank you for making that really important point. I think it slipped my mind. But yeah, I think the BMI is yet another reason to switch over to another medication. So Shema, you said you were nervous and rusty, and yet the video speak for itself. How did it feel?
I have to say, I was totally scared because it started with chest pain. Rabih, I mean, Rabih knows that I have some kind of a cardiophobia recently, like cardio and neurophobia. So it was pretty amazing to have the chance to, overcome a little bit of my cardiophobia. And I have to say, seeing what cardiac, I mean, especially these kind of cardiac complications of lupus, I never really thought directly, especially in the level of the vascular thing, so with the coronary arteries, I never thought about it. So it's definitely something that I have to read about. And my biggest thanks is also going out to everyone also in the chat who participated. I remember I have some brain fog because I didn't read a lot about internal medicine recently, but it still helps me discussing with you all. And thank you, Aisha, for this amazing case presentation. And also, Rabih, always a pleasure to discuss with you. I'm learning always so much.
The pleasure is all mine. I'm stealing all the pleasure. That was amazing. Thank you so much, Shema. It's always a treat to discuss with you, and I am already looking forward to the next time. I have to ask much harder questions. I'm giving myself feedback. Anyway, Tansu has the very hard task of summarizing this incredibly complicated case. So I'll pass the mic to you.
Thank you. It was a great discussion. So we started off with a 35-year-old female patient who had chest pain for 1 week. And when we talk about chest pain, we use our 4+2+2 schema, and nothing changes this approach initially because chest pain is such an important symptom. And even though our patient is a young woman, we should still consider older age-associated causes of chest pain too. But since we are dealing with a young patient here, we should think about past medical history, hypercoagulation, risk factors such as OCP use, and other causes. So when we think about chest pain, we think about two things to start off. Is the pain just the only symptom here, or pain is turning into a dysfunction? And we said longer the pain remains, focused on the pain without this dysfunction, the less likely it is that there is dysfunction. And then pain can be either intermittent and triggered by something, or intermittent and spontaneous. Here we had chest pain with exertion, we had a trigger, and we thought about, given the patient's past medical history of lupus, what are the possibilities with lupus? And there are lung possibilities, coronary and vascular and medication-related possibilities, but lung-related pulmonary issues don't present as chest pain on exertion. They present as dyspnea on exertion. So we focused our attention on coronary and vascular issues here. And then what on physical exam can help us distinguish what to direct our focus here. And we looked for localizing symptoms in the physical exam. And here, one of the localizing symptoms, the most important one, was bilateral lower extremity edema. And bilateral lower extremity edema points us towards the right heart failure. And when there's isolated right heart failure, because our patient's oxygen saturation was normal and her lungs were clear, there are two priorities. One of them is pulmonary hypertension, and the other one is pulmonary embolism and pericardial effusion. But we said pulmonary embolism should not cause heart failure acutely because it can cause cardiovascular collapse, but not enough time to get edema to the legs. So there should be something else at play here. And then we investigated the cause of this patient's situation further, and we ended up at pulmonary embolism with APLS. And we talked about the diagnosis of APLS. And we talked about the confirmatory test in 12 weeks with lupus anticoagulant and other antibodies, but lupus anticoagulant was the strongest predictor here. But we should perhaps still investigate the pulmonary hypertension and to decide whether this is class 1 versus class 4 pulmonary hypertension, we can use VQ scan. That's it.
Oh, amazing. Hey, Shema, how did she do?
Superb, like a Turkish queen.
Tansu, I think there's no better way to end than to emphasize what Shema just told you. A Turkish
Thank
queen.
you.
Congratulations. Congratulations on the highest honor. That was absolutely amazing. It was so well narrated from segment to segment to segment to segment. Really, really well done. Thank you so much. And in 2.5, 3 minutes, it's unbelievable. All right, y'all. We have for everybody on YouTube a very, very special treat for you tomorrow. It's something that we have never done at CP Solvers. I will not tell you what it is because I think it will spoil the element of surprise. But our dear friend Francisco, Ravi, and I will be doing something that we have never done before. And I highly, highly encourage you, if you have that 1 hour slot at the exact same time tomorrow, to join us live. It'll be probably the beginning of a whole new space within CP Solver. So I encourage you to try to be there for the first time tomorrow. Alrighty, with that plug, if you don't make it, I'm kidding. Do whatever you want, but we'll see you there if you're free. Bye.